62-year-old male presented to the ER with confusion and cough around emesis. He has a 20-year history of alcohol abuse and was diagnosed with cirrhosis 6 months ago, but has continued to drink alcohol heavily. Upon a physical examination in the ER, he appeared confused. His blood pressure, pulse, and temperature were all elevated. His abdomen was soft, tender, and positive for a fluid wave, but no peripheral edema was noted. His electrolytes were within normal limits, but his AST and ALT were over 3 times the upper limit of normal, and his INR was 2.2. He was then brought to the ICU, where he was intubated and paracentesis was performed. It showed protein and blood cells in the abdomen. His AST and ALT had decreased to less than 3 times the upper limit of normal, but his INR had increased to 2.6. While in the ICU, he was given acetaminophen, 325 milligrams every 6 hours as needed, in a normal saline infusion. An endoscopy was positive for bleeding esophageal varices. Based on his lab values and confusion, he can be classified as cirrhosis child Pew score of C, and he is experiencing some complications. For the treatment of stage 3 hepatic encephalopathy, I recommend to place an NG tube and to administer 30 milliliters of lactulose every hour until a laxative effect is achieved, and then to decrease the frequency daily to achieve soft stools. I also recommend to discontinue the acetaminophen. For the treatment of bleeding esophageal varices, I recommend to initiate somatostatin 500 micrograms per hour IV for 5 days, and also to initiate cefotaxime 1 gram IV every 12 hours for peritoneal infection prophylaxis, and also to monitor his CBC and electrolytes. For the treatment of ascites secondary to cirrhosis, I recommend furosemide 40 milligrams IV bolus daily, and with that, spironolactone 100 milligrams via the nasogastric tube daily, and also to discontinue the normal saline infusion and to restrict his sodium and fluid intake.